Are we ready to go?
Yes, ma'am, we are ready to go.
Okay. So a very good evening to all and good morning to you, Dr. Mori. I welcome you all and thank you all for joining. So today is the 22nd session of Innovations in Hematology, and the topic for today's talk is cardiac amyloidosis and beyond. So we are privileged to have Dr. Mori with us as the guest speaker today from Mayo Clinic, who needs no introduction and whose work has deeply influenced the amyloidosis and Waldenstrom field, along with Dr. Rahul Bhargav sir as the host, and I will be moderating the panel. So why this conversation now? So in amyloidosis, the cost of delayed recognition, it is not just the diagnostic uncertainty, it is lost organ function. So how this conversation started, I remember mailing sir regarding a complicated relapsed refractory Waldenstrom case which we had encountered, and sir replying to us very nicely on how to go about it. And sir, we have heard you at MSG conference and we love your sense of humor. So the agenda of today's program will keep this tightly structured. I had posted on various platforms for questions and I will try to put those forward and discuss with you after the lecture. And I also request all those who have joined us to please put questions in the chat box. I'll club them and we'll discuss those later. So over to you, sir. I'll stop sharing my screen now.
Thank you, Dr. Trahan, and let's get my talk up.
Right.
Request, yeah, so I'll try again.
Yep.
There we go. Let's just see what's here now. All right, so let me now.
So the slides are visible. It is not yet in the slide play zone. Now it's there.
You're
Yeah.
not seeing it as
It
correctly
is,
yet?
sir, it's visible now. Yes, sir.
Sir, it's in a presenter view.
Okay, I will change it. How's that?
Right. Perfect, sir. Perfect.
Okay.
Yeah.
So I want to just preliminarily, I mean, the real issue here isn't effective therapy, it's getting an early diagnosis before your patient presents with end-stage heart failure requiring pressors in intensive care. And there are some significant workflow issues, I think, to cardiologists that see these patients. And I think the first is automatically assuming that a thickened ventricle represents hypertrophy, when in fact the thickened ventricle might reflect the presence of infiltration, and making the mistake of automatically assuming that a thickened ventricle is valvular disease, hypertrophic cardiomyopathy, hypertensive cardiomyopathy, rather than thinking about infiltration. And the second is a workflow issue, and that I find that cardiologists who frequently see patients with thickened ventricles will do checks for sarcoid and hypertension, but don't put the immunoglobulin free light chain assay into their workflow that would provide for an early recognition of amyloidosis. Now, of course, reminding that there are two types of cardiac amyloid that we need to be aware of. There's the immunoglobulin light chain form of amyloid, where it is the plasma cells themselves that are in the bone marrow that are responsible for the production of immunoglobulins from the bone marrow that infiltrate into the heart itself. And for the cardiologist, the immunoglobulin is made out of two heavy chains and two light chains, and it's actually the light chains themselves that produce the infiltration. And then there's ATTR, which is hepatic-derived amyloidosis, where the liver hepatocyte synthesizes TTR, which can be normal or mutated, which will deposit and infiltrate into the myocardium, as this little cartoon illustrates. And so, unlike AL, where the amyloid is being produced in the bone marrow and ATTR, it misfolds into amyloid fibrils, and as a consequence, it ends up depositing in the heart. And so we're two fundamental different forms of cardiac amyloid with vastly different therapeutic intervention. And the TTR form occurs as a age-related, previously known as senile, deposition of normal TTR. And there's also an autosomal dominant mutated TTR that actually produces cardiac amyloid. So with that in mind, go on to the next slide. Imaging is critical in cardiac amyloidosis. And really the four important things are the EKG. The EKG previously was relatively insensitive, but very recently, last 5 years, artificial intelligence has been applied to these EKGs, and AI is now capable of identifying amyloid with not high specificity, but high sensitivity. Then, of course, there's echocardiography, including Doppler and strain measurements showing thickening, slow relaxation, poor filling, thickening of the valves. There's cardiac magnetic resonance imaging, which has the specifics of nulling of the myocardium after gadolinium enhancement. And then in distinguishing AL from ATTR, there's nuclear cardiac amyloid scintigraphy, which is, depending on where you are in the world, technetium pyrophosphate or DPD or HMDP, all of which are useful in detecting cardiac amyloid. So echo typically is the first suggestion of amyloidosis. And you can see in this echocardiogram dramatic 57/50, not the typical thickening you'd expect from hypertensive cardiomyopathy, which is a clue because these patients have such poor stroke volumes due to the very low level end diastolic volume. So the keys, of course, are thickening of the LV and RV. Then you correlate it with the EKG, because if you're thinking it's hypertrophic or hypertensive, voltages in the EKG should be high, and amyloid is typically low. You get thickening of the valve and the atrial septum. You have restrictive diastolic filling with very early equalization of volume. Cardiac index is down. There's biatrial enlargement. Often a pericardial effusion may be seen. And stress echoes can often give a false positive response because with exercise, the patient's heart speeds up. That reduces diastolic filling time, results in a drop in stroke volume and hypotension. So for the hematologist, we want to talk about global longitudinal strain. And global longitudinal strain is the rate at which the ventricle is shortening. And a normal strain pattern is about -20, -21. You can see this patient has a -15 apical strain, which would be moderately severe cardiac amyloidosis, and is very frequently one of the first clues. But of course, strain imaging is not always consistently used in patients with cardiac disease undergoing echo, quite important in amyloid. So there are a few atypical cases because there are patients that we see where you can have changes that aren't so easy. You can see here the Doppler changes with some level of regurgitation. Here you can see a patient that actually has reasonable function. And basically you can see that one test alone is never going to get you where you need to be, but you need to combine it with the EKG, magnetic resonance, PYP, the immunoglobulin-free light chain, which should be done in every patient with a thickened ventricle without a clear history of hypertension. And both echo, magnetic resonance imaging, and EKG are all now being analyzed with AI in an effort to improve the sensitivity of the diagnosis. So in AL amyloidosis, you can see the immunoglobulin light chains depositing in the heart. And this is a much more serious disease because these light chains are directly toxic to the myocardium. And so you can get, with minimal amyloid deposits, significant decline in function because the light chains themselves have a negative inotropic effect. Typically, in cardiac amyloid, 80% will have organs involved outside the heart. So you can see neuropathy, big tongue, big liver, nephrotic syndrome. There is no correlation between the presence of amyloid deposits and the amount of amyloid and the degree of dysfunction. That's just not well understood. And even with successful treatment, you don't get rid of the amyloid, even though you frequently see functional improvement in these patients. And so TTR, which is a direct infiltrative process, is different from AL, where the light chains are directly toxic. And it's why when you treat AL amyloid, you see very, very rapid clinical benefit, even though it's not possible for the amyloid deposits to have regressed in that amount of time. And so when it's classic, it's pretty easy to diagnose. But of course, the problem comes is that so many patients show with atypical variation in the amount of amyloid, and you get different imaging phenotypes as a result. And I think the three main reasons are because you get toxic damage to the heart due to the light chains that is far greater than the degree of infiltration. Two, vascular amyloid, which can produce a significant ischemic phenotype. Patients get exertional angina, yet when you look, these patients don't show much infiltration. And then deposition in the endomyocardium, which can cause an atypical presentation. And so these are just three echoes that demonstrate AL cardiac amyloid. But again, you know, this can't only be infiltration. On the left, we're seeing minimal infiltration in proven AL cardiac amyloid. This is light chain toxicity. This patient has endocardial
ओके
amyloid, and this is the patient with the
वो क्या चीज है
classic.
वो क्या चीज वो देखो कोई आंटी भी है हाँ तुम देखो दोनों कुछ खेल रहे हैं वो देखो वो तो लाइट भी है वो देखो वो तो बर्ड भी है वो देखो बर्ड ओए बर्ड कहाँ जा रही हो बर्ड आज वो देखो वो बर्ड जा रही है वो देखो ऊपर देखो वो देख 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 बर्ड बर्ड कहाँ जा रही है बर्ड कहाँ जा रही है हाँ बर्ड
So this is
Doc-
classic cardiac
Dr.
amyloid.
Swapnil, please mute yourself, Dr. Swapnil.
With the thickening. And so what are the most important numbers on your echo report? And this is what, for the hematologist, cardiac index and stroke volume are most important. You should not be looking at the ejection fraction. Ejection fraction is very well preserved. They have a normal ejection fraction on a very low end diastolic volume. And so they end up with low stroke volume and low cardiac index. You should look at global longitudinal strain. And you should also look at estimated right ventricular systolic pressure. These are of interest, but these are not critically important in assessing the prognosis. And for the hematologist, the question is, well, we're not used to thinking about stroke volume and stroke volume index, but remember that the cardiac output is the key, and that's the amount of blood being pumped per minute. The stroke volume is actually the amount of blood that is pumped with each beat, and the cardiac output is stroke volume times heart rate. And the stroke volume index is stroke volume adjusted for body surface area. And so you can see here a typical patient who actually has a pretty normal ejection fraction. And the problem is that the end diastolic volume is low, so the ejection fraction is normal, but you end up with a very, very low end diastolic volume. And so you can see here's a patient with an ejection fraction of approximately 50%, where the volume ejected is half of the end diastolic volume. Again, in going through this, stroke volume is a major predictor of survival in patients with cardiac amyloidosis. And this is far more important than septal thickness and end diastolic volume or deceleration time. The amount of blood they're pumping adjusted for body surface area is really a very important predictor of overall survival and is independent of ejection fraction, blood pressure, NT-proBNP and troponin, and strain. It's very simple, and it's, I think, an important thing for echocardiographers to report because it indicates the powerful role of stroke volume index in the overall prognosis of this disease. Again, we're looking at strain, and in hypertrophic cardiomyopathy, strain predominantly affects the septum. And in the anterior septum, which you can see here in blue, is indicative of abnormalities. That's very different from amyloid, where it's global. So when we talk about cardiac magnetic resonance imaging in the diagnosis, we can see a lot of different techniques that can be quite effective in diagnosing amyloid, because you've got, besides live motion structure showing ventricular thickening and poor stroke volume, you can look for T1, and with gadolinium, you can see nulling of the myocardium with T1 mapping. And you can see a patient here where we're showing the active thickened ventricle, poor outcome, but there is gadolinium nulling here, and that's pretty much specific for the presence of amyloidosis. And so it's a pretty simple clue, and some patients come to our attention because the cardiologist sends them for cardiac magnetic resonance imaging, and it's the radiologist who sees the gadolinium nulling that is indicative of amyloid and can be distinguished from other causes of infiltration. It also provides a very important prognostic feature, and that's the extracellular volume, the water, which is both useful in prognosis and may be useful in measuring the benefits of therapy. So hematologists, of course, love numbers, and our numbers, the light chain, the M protein, the urinary protein, are accurate and reproducible, but cardiologists love pictures. And they try to change those pictures in the numbers. That's a lot of interpretive variability by the individual. I do want to make a little mention about cardiac devices in cardiac amyloidosis. Pacemakers are used for the usual indication. It's usually bradycardia. I think it's important to remember that because of the low stroke volume, patients with cardiac amyloidosis generally need a faster pulse. And there are many cardiac amyloidosis patients with a heart rate of 110 to 120, and that rate should not be managed. Some of the problems we see in cardiac amyloidosis is that some patients are treated with beta blockers to try and reduce their heart rate, and this results in significant decompensation because the negative inotropic effect of beta blockers can profoundly reduce overall stroke volume. And so I think by and large, it's pretty wise to avoid beta blockers, even in patients with atrial fibrillation and a rapid ventricular response. Some of the patients do need a sustained heart rate above 100 or 110 in order to maintain their cardiac amyloid. Amyloid does produce cardiac fibrosis, and if a patient subsequently needs a pacemaker in AL, that doesn't mean that the cardiac amyloid is worse, but there's probably some element of fibrosis in the conduction system. Implantable cardiac defibrillators are very, very controversial in AL. The data is lacking. There's not a lot of data about the ability to defibrillate a amyloid heart in VFib or VTAC. Most of these patients actually die of pulseless electrical activity and electrical mechanical dissociation, and implantable cardiac defibrillators. Indications are not well defined and are probably different than they are for standard ischemic disease. Cardiac ATTR is important for the hematologist because you may be referred a patient with suspect cardiac amyloid who has normal light chains, normal serum and urine immunofixation, but a classic echo for cardiac amyloid. You need to realize that all cardiac amyloid is not AL, and that in fact ATTR is far more common L, and in autopsy series at age 80, nearly 25% of patients have ATTR. The clues for ATTR is it doesn't cause renal and it doesn't cause hepatic. It causes bilateral carpal tunnel, including the non-dominant hand, lumbar spinal stenosis that manifests with pseudoclaudication, biceps tendon rupture, trigger finger, and it is related, usually I'd say 85% are men with this disease. And I would say the median age is 70 to 75 at presentation. And it's important again because it's far, far more common than AL, and evolution can occur over years. We've seen patients who have bilateral carpal tunnel. They have a release, tissues obtained for the carpal tunnel. Mass spec identifies the carpal tunnel amyloid as TTR. They have no cardiac dysfunction, and 5 to 10 years later, they do develop cardiac TTR. So it's an early warning signal. Very high prevalence of atrial fibrillation and conduction system disease in ATTR before it causes heart failure. So in a community-based study, this is what we saw. This is autopsy-based, and you can see that over 93 in 8 patients, 10% in patients aged 85%, 70, 78. So really, really common type of amyloid, and has to be considered. And so the important clues in early diagnosis of ATTR cardiac amyloid is someone who has bilateral carpal tunnel syndrome. So if you have carpal tunnel syndrome in your non-dominant hand, and you're not a keyboarder, or you don't have an occupation that requires ambidexterity, having it is important. Older patients with lumbar spinal stenosis, it might be a good idea to check an NT-proBNP just to be sure they don't show evidence of cardiac dysfunction. So for the diagnosis of cardiac amyloidosis, this is our published algorithm. Usually these patients present to the cardiologist with dyspnea, edema, reduction in systolic blood pressure, and they'll usually get an echo that shows thickening of the heart walls. The very first step for the cardiologist, the first step is you need to get a light chain assay with immunofixation and immunofixation of both serum and urine, because those are critical to raise the question, could the amyloid be AL? You cannot make a diagnosis of ATTR cardiac amyloid without normal light chains and a normal serum and urine protein electrophoresis. Now, if you have an abnormal light chain ratio or a clonal, before you do anything else, before you do an endomyocardial biopsy, you need to refer the patient to the hematologist, because the hematologist will evaluate non-invasively, most commonly being a bone marrow and a fat, which if it's positive, you can do mass spec to confirm that it's AL, and you've avoided an endomyocardial biopsy. If amyloid isn't present in the fat or bone marrow, and your clinical suspicion remains high, then you might need to do a cardiac biopsy to confirm the diagnosis. If the patient has classic echo findings for amyloid and the light chains and immunofixation are normal, you should be suspicious of TTR cardiac amyloid. And the next step would be scintigraphy with either PYP, DPD, or HMDP. And if there's grade 2 uptake or better with normal light chains, you have a diagnosis without requiring a biopsy. A biopsy is not required to establish a diagnosis of ATTR cardiac amyloid. However, it is required for AL. You cannot make a diagnosis of AL without tissue. If you've confirmed TTR cardiac amyloid, you do need to do genetic sequencing to be absolutely certain this is wild type and not a hereditary form of cardiac amyloid. The use of cardiac amyloid scintigraphy really has improved our ability to diagnose it, resulting in, now we're seeing 100 a year with this at Mayo Clinic. But sometimes you can overread these things. And here's just some examples of accurate use of cardiac scintigraphy for the diagnosis of ATTR cardiomyopathy. So this is a patient here who had a positive PYP scan, but it turned out this patient had AL amyloidosis. The light chains were markedly elevated, and the patient had a monoclonal lambda protein in the serum. And this was positive because you can get grade 1 positive PYP imaging with AL amyloid. So you need to be sure those light chains are normal. Now, here's a patient who's basically the heart looks like it's positive, but when you do tomographic imaging, SPECT, you find that the technetium uptake is not in the myocardium. The myocardium is negative. It was all in the blood pool being ejected. And so with the use of tomography, you can see PYP uptake in the ventricle. This is an accurate diagnosis of ATTR cardiomyopathy. And finally, here's a patient who had a negative PYP scan, but a very abnormal echo, and ended up getting a biopsy that did show mutated ATTR, because there are some mutations of variant ATTR that cause cardiac amyloid but are negative to PYP. So the big three mistakes when cardiologists see positive scintigraphy is not screening for AL with light chain, not doing tomography to be sure that the uptake is in the myocardial wall, and never doing biopsies when the index of suspicion is high, no matter what the imaging shows. It's of course important because we have excellent treatment both for AL amyloid and TTR cardiac amyloid. In TTR cardiac amyloid, we have gene silencers that stop the liver from producing transthyretin. It shuts it down. There are 3 approved drugs that will stop it, and this has been shown to improve 6-minute walk, Kansas City quality of life, and hospitalization and cardiac death. Experimental gene editing is underway where CRISPR-Cas9 is actually shutting down the TTR gene, so TTR production, but this remains investigation. We have in the United States tafamidis and acoramidis, which are TTR stabilizers, where they bind to the TTR and prevent it from dissociating in the amyloid. And if those are not available, diflunisal, which is shown to be beneficial in TTR neuropathy, has been used. There are also 2 trials of amyloid antibody depleters that include Alexion's compound and coramitug. Those have currently been shown to preliminarily be active, that actually deplete amyloid deposits after they've been deposited. And for AL amyloid, kappa type cardiac stage 3, there's also an antibody that is not yet approved but will likely be submitted to the FDA, that in advanced cardiac amyloid, when combined with DARA, bortezomib, cyclophosphamide, and dexamethasone, improves survival, but only in kappa light chain cardiac amyloid. So this is just a little box just to show you that tafamidis is approved for cardiomyopathy, both variant and wild type, as is acoramidis. Patisiran is approved only for variant neuropathy. Vutrisiran, which is given sub-Q every 3 months as a gene silencer, is useful for all forms of ATTR amyloid. And eplontirsen is approved for neuropathy, but will be submitted to FDA for approval for cardiomyopathy, is pending. How to choose among treatments? There are no head-to-head studies. There's no cross-trial comparisons. And so we really just can't make any stat. The patients being seen now are much less advanced than they were when the original trial. So patients who were treated with tafamidis had much more advanced disease compared to the patients who received acoramidis or vutrisiran. But what we do see is that all the drugs slow the rate of progression. They don't cure the disease. And when you look at the decline at 1 year in the 6-minute walk test, you can see a healthy adult over a year loses 5 meters. Patients who received tafamidis, 7 meters. People who received vutrisiran, 22 meters. And people who received acoramidis, 56 meters. But all of those showed significant improvements compared to placebo. All of them did. But you can't do a cross-trial comparison because of the different severity of the disease at diagnosis. The ACC has published management guidelines last year, emphasizing individualized management with disease-modifying therapies, tafamidis, acoramidis, and vutrisiran, the 3 approved drugs, but really no evidence of superiority and nothing to suggest that combination therapy is better than single-agent therapy. So routine use of combination therapy is not recommended. You pick one. These are some of the ongoing ATTR trials. Eplontirsen is going forward with approval for cardiac TTR. Coramitrig is an amyloid depleting antibody enrolling. Nucresiran is another gene silencer, but it's given subcutaneously every 6 months. This is the gene editing CRISPR-Cas9, the Nexiguran. Alexion has its antibody depleter. And then acoramidis is actually looking at treating patients with mutant ATTR in a pre-symptomatic phase in an effort to prevent the development of cardiac amyloid. So there's very, very good treatment of ATTR, but we don't know what's the best treatment. We don't know if these treatments are useful in extra cardiac involvement. Currently, therapy is indefinite, but we don't know if we can stop. We don't have long-term data on the long-term suppression of TTR with gene silencing or gene editing. We don't have a good way to determine when treatment fails, and we should switch to another therapy. And even the best way to monitor these patients is unclear. For the monitoring of cardiac amyloid, of course, it's important that imaging, serial imaging, these slides show patients with cardiac amyloid, and this is a patient with a pulmonary capillary wedge quite high at 28, and the biopsy showed ATTR wild type amyloid, and the cardiologist made the diagnosis. And it's important because only 10 to 15% of ATTR is in women, and so it's probably underdiagnosed. And it's important to remember that women with atypical thickening of the ventricle, they also need to be considered for ATTR cardiac amyloid. In the autopsy studies, the male to female ratio is almost 1-to-1, but in the clinically reported studies, the ratio is 5-to-1. This is a patient who is now 86 after 10 years, who echo went from relatively atypical um, and then evolved over a period of 8 years into a 16 millimeter posterior wall, but really very little change in LV strain, 6-minute walk test, or diastolic function. So there's a lot of atypical presentations that we see with these patients. This is a 55-year-old male who was asymptomatic, and the EKG was abnormal. And you can see the left ventricular free wall was 18 millimeters. The patient had a positive pyrophosphate scan, a negative serum and urine immunofixation and free light chain, and was diagnosed with wild type TTR amyloid at age 55, which is very, very atypical. That's awfully, awfully young, but it happens. The clinical course of this patient at the time of cardiac cath showed the high wedge pressure, a good cardiac output of 4.4, pretty good, an LV strain that was markedly abnormal, and a superb 6-minute walk test. The patient underwent atrial fibrillation ablation, remained in sinus rhythm, and started running 3 miles per day after the patient was initially treated with diflunisal before trials were available, tafamidis from the open label extension, and then eventually got a TTR silencer showing dramatic benefit overall. At age 76, 7 years on therapy, no diuretics, no SGLT2s, 6-minute walk test improved by 62 meters in 6 minutes, and the NT-proBNP fell by 50% from 1,500 to 700. So the natural history is rapidly changing, and it's important for cardiologists to be aware. But again, if there's a light chain abnormality, referral to the hematologist for biopsy verification, exclusion of multiple myeloma, and then the institution of highly effective anti-plasma cell chemotherapy is important. Keep in mind that you want to try to avoid beta blockers at every possibility. So I'm going to summarize, and I'm going to leave a lot of time for questions. We're seeing amyloid earlier. We're seeing different phenotypes, and a lot of the things that you learned about granular sparkling appearance on the echo, low voltage EKG, you have to have periorbital purpura in AL or a big tongue. None of those are valid. The majority of patients don't have any of those things. The cardiologists need to have hematologists to integrate care, because you never know from the echo what's ATTR and what's AL, even if there are minor changes in the light chain. We need to see the patient to establish a diagnosis, obtain the mass spec to verify the type of amyloid, and then institute the antiplasma cell chemotherapy while we work with the cardiologist for rhythm control, diuretic management, anti-arrhythmics. I think with that, I will stop. I wanted to leave a lot of time for Q&A, and I'm happy to take questions both from cardiology as well as from hematology, and I will stop sharing my screen now. Thank you.
Thank you for the excellent lecture. Very practical, and thank you for including so many videos. Happy to share, we had around 243 registration all across Southeast Asia. And before the lecture, I had put on various social media platform and WhatsApp group and collected a long list of questions. So
Okay.
before I take up those questions, I request anybody, if they have any question, to put up in the chat box, or if you want to discuss with sir, you can discuss directly. So one question we have in the chat box by Dr. Abhinav, asking how accurate is the IHC of tissue in characterizing amyloidosis, and any experience with co-occurrence of AL and ATTR type of amyloid in biopsy.
So I'll say that immunohistochemistry is here's the thing: mass spec unequivocally is the gold standard. Unequivocally. The problem is it is not widely available and it's hideously expensive. And sometimes that puts it out of reach. But I will tell you that when you do a head to head comparison of immunohistochemistry and mass spec, immunohistochemistry is significantly inferior. Now, here's the pluses and minuses. For ATTR, for ATTR, immunohistochemistry is pretty good because there isn't a lot of differences that won't be picked up in immunohistochemistry. But for AL, it's just bad. And let's explain why. Commercial anti-sera that you use for immunohistochemistry is usually created how? It's at the constant portion of the immunoglobulin light chain. That's the kappa and lambda antisera. But in amyloid deposit, the constant portion is deleted. The misfolded light chain is almost only the variable part of the light chain. We know that, for example, the light chain has a molecular weight of about 25 kilodalton. But when you look in the amyloid deposits, the proteins are 12 kilodalton because about 50% of the constant portion is deleted. So the light chain is missing. Secondly, as you know, amyloid characteristically misfolds. And the epitopes on the light chain, the kappa and lambda, often misfold and are internally buried. And so you end up with high background with immunohistochemistry and AL. And I've seen patients referred with obvious AL amyloid with lambda light chains of 1,000 milligram per liter, and the immunohistochemistry reads out AA, ATTR. Finally, to keep in mind for non-cardiac amyloid, it isn't just AL and ATTR. You have AA, A beta to M, A insulin. There's 100 different types of amyloid, and you don't have 100 anti-sera in your immunohistochemistry panel. So if you have, for example, A fibrinogen amyloid or A beta 2M amyloid, and you're just staining for TTR and AL, you're never going to make those diagnoses, but you don't with mass spec. Those get sequenced and you know immediately. So look, if you don't have access to mass spec, you've got immunohistochemistry, but make no mistake, it is an inferior technique and sometimes, frankly, misleading, particularly in AL.
Right, sir. Thank you. So, more of questions on AL amyloidosis I have received, and the most common one which I got was that after starting the patient on DARA VCD frontline, so what is the duration of the treatment? Do you continue to give DARA maintenance, or you stop therapy, or it is an individualized treatment decision?
Well, no one knows the answer. And we have a clinical trial at Mayo so you know the VCD is 6 months and stop.
Right.
And according to Andromeda, you're supposed to continue DARA for 2 years. But we have no idea if you really need to give DARA that long, particularly now that we have measurements that will verify stringent complete response. And in amyloid, we can detect MRD negativity with DARA VCD. So we do have a clinical trial that randomizes patients between the standard Andromeda 24 months of DARA versus 12 months of DARA, where you finish VCD and get 6 months of DARA. But right now, I'm afraid there's not a evidence-based answer that I can give you about whether really the trial 24 months is really necessary in patients who have a sustained deep response.
Right, sir. So another question from the chat box. How do you approach autologous BMT in patients with cardiac and renal amyloidosis? And
Right.
sir, as you know, in India, not all of the patients can afford DARA. So what is the maintenance therapy for patients who are started with VCT per se for AL amyloidosis?
Right. So currently, the way we're using transplant is, first of all, let's start with the general amyloid population.
Right.
If you look at Andromeda, 60% of patients achieve a CR. Well, that means that 40% of patients didn't achieve a CR. They still have a persistent light chain abnormality. This is not multiple myeloma. With multiple myeloma, you can achieve PR, and these patients can do exceedingly well, even though they have persistent immunoglobulin abnormalities. That's not the case with amyloid. If you still have elevated light chains, you're still depositing amyloid in tissues. And so, under those circumstances, what will you do to try and bring the patient into CR? And in those circumstances, for patients who don't have a CR, autologous stem cell transplant still remains a highly, highly effective technique. But you've got to be selective. So if the patient has a creatinine clearance below 30, they're not going to do well with high dose melphalan. They're going to be a high incidence of acute tubular necrosis, and you're going to end up putting those patients on dialysis. So we're not doing those patients. In addition, patients with very advanced nephrotic syndrome who have very low serum albumins, below 2 gram per deciliter, those patients get high dose melphalan, and the kinetics are very, very different. The toxicity profile is much higher. You have to prepare yourself. Selecting cardiac amyloid patients for autologous stem cell transplant requires a lot of integrated care with cardiology. We won't take them to transplant without cardiology clearance, but I'll tell you a couple of things. If their systolic blood pressure is below 100, you need to be cautious, because what's going to happen with these patients, let's say they have a 90 systolic blood pressure, you transplant them, they get neutropenic fever due to bacteremia, and then all of a sudden they start developing a low peripheral resistance, they get hypotensive. In a normal patient getting a transplant with myeloma, cardiac output improves, blood pressure improves, you carry them through. But in amyloid patients, already maximal cardiac output. So once they get hypotensive, they can't improve their cardiac output. And when that happens, that hypotension is going to result in hypoperfusion, lactic acidosis, and you know the outcome with lactic acidosis. So the big things are, what's your systolic pressure when you begin? High sensitivity troponin is very important. If you have a high sensitivity troponin over 100, there's so much cardiac cellular damage, you're going to have a high mortality with transplant. We will elect not to transplant those patients. And so, close working with the cardiologist as to, will this patient be able to survive neutropenic fever or a renal insult becomes a big deal. But for the patients who don't achieve a CR with DARA-based therapy, and if you can't afford DARA-based therapy, VCD only gives you 30% CR rate. So now you have 70% of patients who would be eligible for stem cell transplant. It remains a very important consolidation therapy.
Right. And so, what maintenance do we offer to patients whom we have started on VCD?
So in a typical amyloid phenotype, which normally is 11-14 translocation, no adverse genetics, presented 5 to 10% plasma cells, no maintenance therapy at all, because these patients have an MGUS phenotype. But you'll sometimes see amyloid patients who present with 40 to 50% plasma cells, or they'll have a minus 17p, or a high proliferative index, or a 414 translocation. And under those circumstances, that's more of a myeloma phenotype. And then we would tend to offer these patients maintenance therapy the way we would do a myeloma patient.
Right. Right. So, you mentioned 11-14. So, the next question which I had was, so as a second line, so do you offer venetoclax to patient with 11-14 translocation? And another thing which I have got from a lot of people is that people are scared to give IMiDs, pomalidomide and lenalidomide, with this fear that it might precipitate heart failure. So, where do you place the role of IMiDs and also venetoclax?
All right, I'll start with, first of all, second line therapy. Let's say you failed VCD and you're not a transplant candidate. You really have 50% of patients will have an 11-14. The decision you have is between venetoclax, which has a very high response rate, and T cell redirecting therapy. Because in this space in amyloid, bispecific antibodies, CAR T, and belantamab have all shown very high response rates. Now, obviously, venetoclax is the safer of the two because it's oral, it's not associated with cytokine release syndrome, it's not associated with the high infection rate. But if you compare the complete response rates to venetoclax to T cell redirecting therapy, CR rates are much higher with T cell redirecting therapy. So it's not a very easy decision. And so you start thinking about how frail is the patient? Is T cell redirecting therapy a realistic option for financial reasons? That may not even be an option. What is the access to venetoclax, which is only useful in the 1114? But we absolutely will use venetoclax as second line therapy in 1114 if we think that that's a superior choice to T cell redirecting therapy. You have to keep in mind that although response rates are high, complete response rates are not that high. There is no question that IMiDs are toxic in patients with cardiac AL amyloid, and they really are best avoided. Because pomalidomide and lenalidomide cause decline in cardiac function so frequently, it's why we're using VCD instead of VRD. However, about 40% of amyloid patients don't have cardiac involvement at all. They're renal, they're hepatic, they're nerve, they're soft tissue. In those patients, lenalidomide is a completely legitimate choice. In patients that have cardiac involvement and you're contemplating use of an immunomodulatory drug, you don't want to do it without the cardiologist on board. I don't use it very much because they really are toxic. Patients get worse. NT-proBNP really goes up. And just as a note for the hematologist, if you're contemplating an IMiD, the lenalidomide starting dose is 5 milligrams. You can escalate from there. Do not try to give cardiac amyloid 25. And the starting dose of pomalidomide is 0.5 milligrams. You don't want to start someone on 4 milligrams. And you can escalate and see. Not everybody decompensate, but enough of them do that you got to respect those drugs. They are tough in cardiac amyloid.
Right, sir. Thank you. Sir, a question by Dr. John in the chat box. A patient of renal amyloidosis was started on VCD. Post 2 cycles, there was 90% reduction in differential free light chain. However, patient developed severe bortezomib-related neuropathy. There's no affordability for DARA. And what next options to consider provided the patient is also transplant ineligible?
So, already things are in a good place because you're 90% reduced. So you've got a VGPR, and so that's excellent. But if you are trying to get to a CR, I think this is a place, if the patient doesn't have cardiac amyloid, where you actually could add lenalidomide in a low dose, see if the patient tolerates it, and then use lenalidomide with cyclophosphamide and dexamethasone. And this would be a place where you really want to know the 1114 translocation status, because remember, in myeloma it's 15%, but in amyloid it's 50%. And so if you get that kind of level of 1114, venetoclax does become an option for you.
Right. So, two more questions in the chat box. First, by Dr. Akash. How do you manage cardiac AL amyloidosis without DARA? And VCD is enough, and what all supportive management should we offer to the patient?
Well, VCD is what you've got. I mean, in a patient with cardiac ALM, you don't have DARA, you go with VCD, you still have a 30% complete response rate, and organ response rates are 20 to 30%. So it's not a hopeless situation. It's just not as good as if DARA was available. But realistically, the mainstay of treatment in cardiac amyloid is diuretics. It's diuretics. And so it becomes important, and oftentimes you need to do this in conjunction with cardiology because their ventricle is so stiff and fills so poorly in diastole. Some of these patients need a pretty high filling pressure on the left side in order to distend the ventricle to get a decent stroke volume. So your goal is not eliminating edema. Some patients need to have excess intravascular volume in order to distend the ventricle. So you're using diuretics if there's volume retention, not everyone does, based on blood pressure, NT-proBNP, and symptoms. But these are things where cardiology is incredibly helpful because it's not like a patient who just has orthostatic edema where you're just trying to get their edema down so they can fit their shoes on. These patients sometimes you can overdiurese them pretty easily, and you can take a cardiac amyloid, and in your attempt to make them euvolemic, you can get them syncopal pretty fast. And so this is also joint management with cardiology because the requirement for intravascular volume is very different.
Right. So, question by Dr. Mitu. In a transplant eligible patient with cardiac amyloidosis, what is the right time to take the patient up for transplant?
We would normally do 4 cycles of induction therapy, and if the light chain involved has plateaued, we don't want to take them to transplant. If it's continuing to decline, we want to get the maximum reduction. But usually, after 4 months, you'll see the light chains have plateaued, and once they're plateaued, you're ready to go to transplant. But you just want to be sure that you've squeezed the maximum amount of light chain reduction with the VCD therapy.
Right. So, one more question before we close the session, because since we are already approaching the time, I received this question online that how do you approach a patient with excellent hematological response but ongoing cardiac or renal progression? What is the right time to wait for that response? And if that response is not being achieved, how do you go about it?
So that's really where we are now with amyloid and why we need amyloid antibody depleters is because what we do now is we treat them with anti-plasma cell chemotherapy and then we pray for an organ response because all we do is stop production and hope that the organ resolves. But if you look at Andromeda, in the patients who achieve a CR, the organ response rate is still only 60% heart, 55% kidney. There's still plenty of patients who don't get an organ response despite eradication of the plasma cell clone. We do not understand why that is, but regrettably, there's not much we can do about it. There are plenty of patients with renal amyloid who get complete immunologic response and end up on dialysis 3 years later, and patients who go on to succumb to cardiac amyloid. And so it's really an unmet need because there's no role for any additional chemo. You've already gotten rid of the plasma cell clone. And so that's why kappa light chain attacking cardiac deposits are important and why exploration into anti-amyloid antibodies to remove existing amyloid deposits is so very important, is our next step beyond anti-plasma cell chemotherapy.
Right, sir. So before we close the session, one take-home message you would like to give to all the people who are listening to us live.
Yeah, so the big issue here is workflow because you know what the treatments are. Everybody's using these treatments. It's not the treatment, it's getting a diagnosis before renal failure, before cardiac failure sets in. So the workflow for any nephrologist, every patient with proteinuria that is not diabetic, you ought to do a light chain assay. And for cardiology, you have patients with heart failure preserved ejection fraction. That terminology, that's not a diagnosis, that's a description. Every patient with HFpEF needs an immunoglobulin-free light chain assay. Some of them need pyrophosphate imaging. All patients who have a thickened ventricle that you think is hypertrophic or hypertensive, but there's no history of hypertension or the EKG doesn't show high voltage, you need to get the light chains because that will open up the answer.
Right, sir. So thank you so much. It was lovely talking to you. Very engaging session, and thank you for taking up this class. I'll be in touch with you, sir. Thank you very much. Bye, sir.